Good afternoon. My name is Justin, and I will be your conference operator today. At this time, I would like to welcome everyone to the State and County Health and Diversity Measures Are We Moving the Needle? All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Dr. Winifred Quinn, you may begin your conference.
Great. Thank you so much, Justin. Good afternoon, everybody, or good morning for those of you farther west. And welcome to our webinar where we are updating you on our dashboard measures around diversity. And we're also sharing with you how you could relate those to RWJF's Culture of Health framework. And also we will be talking about the county health rankings, RWJF's county health rankings too, so you could learn more about your state's health and who you're serving. We also want to discuss how this information and data can be used to help you engage new and existing stakeholders, which of course you know is always something that we highly encourage you to do, and how culture of health concepts can be used in in your Action Coalition's sustainability efforts. Before we go any further, I do want to mention that we are recording today's webinar. So if you missed something or would like to pass it on to a colleague, which we highly recommend, you can find our recording next week by going to www.campaignforAction.org/webinars. Also, we will take your questions over the phone at the end, but we also do encourage people to send questions in the chat function, and be sure to send them to all or to everyone when you do so. So at this point, I am very happy to hand over the facilitation of today's webinar to my friend and colleague, Dr. Adriana Perez. Adriana?
Yes, thank you so much. I'm equally excited to introduce our guest speakers today. They have worked very hard on this presentation over the last several weeks. First up, next slide, we have Dr. Joanne Spetz. She is a professor at the Philip R. Lee Institute for Health Policy Studies and Associate Director for Research, Health Force Center at the University of California, San Francisco. Dr. Spetz is a data advisor to the Center to Champion Nursing in America, and so you will hear from her about sources of national and state level data regarding diversity, and she will explain the diversity dashboard measures. Joining her today, we have, in our next slide, we're excited actually to bring to you today the co-chairs of our Diversity Steering Committee. First, Dr. Deborah Washington. She is a Director of Diversity for Nursing and Patient Care Services at Massachusetts General Hospital. She has been there since 1995. She is the National Co-Chair of our Diversity Steering Committee and also serves on several diversity advisory committees for schools of nursing for both baccalaureate and associate degrees. In addition, Dr. Carmen Alvarez, an assistant professor at the Department of Community Public Health at Johns Hopkins School of Nursing, is our co-chair. She has been with us for at least a couple of years, and we're very happy to have her. Her research focuses on developing interventions for the primary healthcare workforce serving low-income populations in the U.S. and abroad. You can see here that our Diversity Steering Committee will talk about how diversity fits within the action areas of the Culture of Health framework. And Dr. Alvarez will lead our discussion towards the end. And with that, I will turn it over to Dr. Spetz.
Great, thank you. So the primary diversity dashboard indicator, as many of you have probably seen, is pre-licensure nursing program graduates by race, ethnicity, and by gender compared to the U.S. population. In the bar graphs that you can see now, you can see that the current racial and ethnic distribution of our nursing workforce of the graduates in 2015. or 2016, I believe these data are from. So the goal here is to prepare a nursing workforce that will ultimately better reflect the diversity of the population that they serve. So that means that we need to be looking at ways to bring the gender balance of the nursing profession and the racial ethnic diversity of the profession in line with the population of the U.S. as a whole. As of 2015, the baccalaureate and graduate nursing student population was still overwhelmingly female, and that continues to be the case. So next slide, please. So there are several different ways that you can, or sources of data that you can try to use to look at the diversity of the nursing workforce. And as I mentioned, the top level indicator is the diversity of new RN graduates, which is more rapidly affected by current actions. We really can't change the diversity of the incumbent population, but we can change the new graduate diversity relatively rapidly. We are tracking as secondary indicators, which you can find on the Campaign for Action website, the diversity of the total RN population, the diversity of new graduates by degree type, and then the diversity of nursing doctoral students. Next slide, please. We also were looking to look at the data on pre-licensure RN graduates. We've been using the Integrated Post-Secondary Education Data System, which is known as the IPEDS, and that's administered by the U.S. Department of Education, and we use that for associate degree and diploma graduates. But in that data set, baccalaureate graduates are not distinguished by whether it is an entry-level degree or it is an RN to BSN degree. So we do not use that data source for bachelor's degree diversity. For bachelor's degree diversity, we use the American Association of Colleges of Nursing data because that data source provides the similar information but focus on entry-level graduates as distinct from RN to BSN graduates. We compare these to U.S. population data that are from the U.S. Census Bureau. Next slide. You can see in this diagram the diversity of pre-licensure RN graduates over time since the campaign began in 2011 through the most recent year of data available, 2016. You can see that there's been some gradual, slow improvement in the diversity of pre-licensure graduates with improvements across many of the different racial and ethnic groups, including notably African American and also Hispanic and Latino. The share of RN graduates who are of Asian race ethnicity has been fairly stable, and there has been some growth in those identifying themselves as being multiracial, as well as very little change in some of the other groups, including, say, Native Hawaiian and also Native American. It's very important to note the areas where there has been a lack of clear change over time because those are some opportunities for us to do better. Next slide. This slide presents the RN graduation diversity versus the U.S. population diversity for 2011 and for 2016. So in both of these comparisons, the left pair of bars are for 2011, the right pairs of bars are 2016, and in both of those pairings, the left bar is RNs and the right bar is the U.S. population. So focusing on the most recent year of data, you can see that about 61% of the U.S. population is white, and then there is quite a diversity of other racial and ethnic groups represented, whereas for registered nursing graduates, we are still at over 80, at about 66% white of the new graduates, and we are notably underrepresented for certain racial and ethnic groups, including Hispanic, Latino, Black, African American. The representation for Asian overall is about right. However, we also want to note that that we do not have good data on Asian subgroups within these data sources. And so it is our understanding from some of the state-specific data that we've looked at that Filipinos are somewhat overrepresented in the RN population, and then other Asian groups such as Southeast Asian and East Asian are underrepresented in the nursing population relative to the U.S. population. Next slide. This chart shows the gender diversity of our pre-licensure RN graduates. There has not been a lot of change since about 2013. We've been holding pretty steady at new graduates being about 13.7% male after some improvement between 2011 and 2013. So we could be doing better in recruiting young men and older men into the nursing profession than we haven't had a lot of progress in the past few years. Next slide. No surprise if we compare the diversity of the nursing workforce or the nursing graduates to the U.S. population as a whole, we're nowhere near 50-50. Next slide. So in looking at the total RN population, which we also think is important to track even though it can't change as rapidly as the new graduate diversity, we are primarily using the American Community Survey, which is a product administered by the U.S. Census Bureau. It's conducted monthly, and then there are annual releases of the data. For those people who are familiar with the census data, there used to be with the every 10-year census a long form and a short form, and this is essentially an annual replacement of the old long form. RNs in this data set are identified by their self-reported occupation, which means they need to be currently working or they need to be unemployed but reporting that their normal occupation is nursing. That means that people who are licensed as registered nurses but might be working in a different occupation or categorized by the Census Bureau as being in a different occupation might not be identified as RNs, even if they are maintaining an active license. So that is one limitation of the data that probably doesn't affect our interpretation of the trends very much, but is worth keeping in mind. Next slide. So this chart shows the total RN population over time and its diversity. As you can see here, my apologies for these legend numbers overlapping a bit, but the overall RN population is about 72% white, and then smaller percentages of all the other racial and ethnic groups being non-white of the various groups. There has not been a lot of change, actually, in the total population since about 2014. But as I noted, the total population of nurses is very large. It's, over 3 million nurses in the United States. So the numbers of new graduates coming in each year can only move the overall population diversity modestly. But we should be paying attention to what kinds of changes we might be able to make to accelerate the inflow of new graduates that then will change the diversity of the population over time. Next slide. If you look at the total RN population's diversity versus the U.S. population diversity, there has been some improvement in how the nursing population compares to the U.S. population, but it's been very modest. The U.S. population continues to become more diverse, and the nursing population is becoming more diverse, but again, the movement has been slow, and we still have about 11 percentage points more whites in our nursing population than the U.S. population, and we have notable underrepresentation, particularly among Hispanic and Latino nurses, and relatively little change in some areas, in some population groups, including American Indian, Alaska Native, and the Black and African American population is not growing as rapidly among our nursing workforce as might be ideal. Next slide. This chart looks at RN graduates' racial and ethnic diversity by degree type. And this is interesting information because it does shed some light as to how the different educational programs in the U.S. are contributing to the diversity of our workforce. The first thing to note is that the graduates of all types of nursing programs between 2009 and 2016 have become more diverse. So that is the very good news. It also is worth noting that the diversity of the entry-level master's students tends to be a little bit greater than among the associate degree and bachelor's degree nurses, but it's also worth noting that little sage green top bar is people whose race and ethnicity are unknown. And that would be because the nursing schools reporting the data didn't indicate what the race ethnicity of those groups were. So while it appears that the entry-level master's students are less frequently white than other students, we also have a larger group of those students where their racial and ethnic backgrounds are unknown. So we can't say for sure that the students from those programs are more diverse. But in general, the diversity of the associate degree and the bachelor's degree students are similar in many respects. The associate degree programs have somewhat higher shares of Hispanic and Latino nurses, as well as Black and African American new graduates, and somewhat lower shares of Asian new graduates in their overall graduation mix. Next slide. So this slide presents similar data by gender diversity, and it's worth noting here that the associate degree and the entry-level master's degree programs in 2016 had higher shares of male students than did the bachelor's degree programs, but these differences are all pretty small. They're within 1 percentage point of each other. Next slide. We also have been tracking the diversity of doctoral graduates. So these data are the graduation diversity for the PhD and DNP students. Of course, the number of DNP graduates has grown tremendously between 2010 and 2016. And as those numbers have grown, so has the diversity of the DNP graduation population. That diversity has grown most notably, I would say, for the Black and African American nurses. Asians, who were almost non-existent in the 2010 data, and now are 5.2% of new DNP graduates. And also there's been some growth in Hispanic and Latino DNP graduates. Among the PhD programs, those graduates are also becoming more diverse for pretty much every racial and ethnic group, although there has been a drop-off in non-U.S. resident graduations among the PhD programs. And that may be the result of broader trends in immigration in the U.S. The next slide presents similar data for doctoral graduates by gender diversity. Again, the share of men coming out of our doctoral programs has been rising over time, both for the PhD and for the DNP program. So this is another piece of good news. Again, though, we have a long way to go in improving the diversity of our doctoral graduates, many of whom are going to be our practice leaders and our faculty leaders of the future. So now I hand this back over to my colleagues.
Thanks, Joanne. As we take a look at how we might use data, let me make this statement. It's important to work with the community. An example is shown on this slide related to the background of one AARP volunteer who presented at my organization during Black History Month. This is an example of how to take advantage of community-based volunteers and their expertise. I came to know the invited speaker in her role as an AARP volunteer. Her interest is to work to enrich and empower older adults. As an example of this, in 2017, she helped coordinate a healthy aging event at a local center in our Roxbury community near Boston, which is a predominantly Black community. This AARP volunteer is a member of the City of Boston Mayor's Advisory Committee, where she advocates for community issues. She spreads the word about the work, and she encourages community participation as well as seeking their feedback. She also consults with research conducted by the McCormick School of Policy and Global Studies at the University of Massachusetts, Boston. She promotes research and public policy to develop evidence-based best practices and model programs. She helps build capacity in community service organizations, and as a community activist, she also teaches community-based healthy cooking classes, promoting good health through a nonprofit that's focused on food and nutrition education. And she proudly identifies herself as a Bostonian born at a minority-serving hospital in Metro Boston, an incredible human being who is actively working with the local AARP chapter. I put her forward as an example of you never know where you're going to find expertise, so we should always be casting a large net. She is exactly the kind of volunteer that would make a difference in our state action coalitions as we build our culture of health agenda. On this next slide, we have a map from the Social Capital and Health Outcomes in Boston report. And it shows the life expectancy ranges in the city of Boston, where you can see there is a low of 59 years to a high of 92 years of life, with the average life expectancy of around 78 years. The two darkest shades that you see on the map shows life expectancy below the average. It raises questions about the living conditions, the social determinants, or the culture of unhealthiness, if you will. So the question is, what explains the 17-year span of living or dying in the range of 59 to 76 years in some of these areas? We need to pursue the answer to big questions like this. One starting point of discussion for us in Boston was that in December of last year, the Boston Globe Spotlight team did a series on racism in Boston. One article in that series was called Color Line Persists in Sickness as in Health, and it examined the issues of racism in Boston when talking about the topic of health care. The article makes note that the world-renowned hospitals of Boston are underutilized by minority residents, and that white residents will bypass a minority-serving hospital to get their care elsewhere. The article states that certain patterns of segregation remain stubbornly entrenched, threatening to undermine the region's mission of equitable care for everyone. In this next slide, we go into further detail. The distortion on the slide is deliberate so we can better see the smaller areas. Life expectancy varies by almost 33 years between census tracts. Affluent Charles River Basin in Boston, you'll find the longest life expectancy of 92 years. When you take a look at two economically depressed areas in the minority community of Roxbury, which is predominantly black, you'll find the shortest life expectancy at 59 years. These two areas fall below counties which represent the same kinds of life expectancy data that we'd see in countries like Cambodia, Gambia, and Iraq. So why is this? We need data, and we need to utilize data to try to explain this phenomenon of life expectancy in this kind of example. And moving to the next slide, one source of data, and you probably know of others, is the community profile reports. And here, in these kinds of reports, you can compare outcomes in Roxbury to city and state averages. You'll also find over 100 indicators of individual and community health issues like wellness and prevention, nutrition, chronic diseases, mental health, and disabilities data for over 351 cities and towns and around 60 neighborhoods in Boston. That 2017 community event I mentioned earlier provided insight into the community's health concerns. The members of those communities mentioned they had three top priorities. Those priorities were diabetes, hypertension, and obesity, and they wanted these priorities addressed sooner rather than later. And they felt addressing obesity, interestingly enough, obesity and its root causes, if we examine those, we would benefit from outcomes from some of these other priorities that they were concerned about. Their other concerns were focused in on prostate cancer, congestive heart failure, and poor mental health days. And things didn't stop there for the members of these communities. They had other areas of concern. These other areas of concern included physical activity, poor overall health, lower rates of preventive vaccines, kidney disease made the list, inadequate consumption of fruits and vegetables, tooth loss, smoking, and lack of emotional support made the list. The primary data sources used to support these concerns that they were legitimate. We used census data, behavioral risk factors, surveillance survey data, and Centers for Medicare and Medicaid Services data. In the next slide, we want to emphasize that these days we need to tell data-driven stories. We need anecdotal evidence, but the real drivers these days are data. Less text, more data. We're a Twitter concise society. Infographics are gaining ground as a way to make important points. And to that end, knowing where you stand is important. The Globe article that I referenced earlier noted that Black people suffer far worse health overall than whites because of poverty and environmental reasons. The article went on to say that Boston city planners confirmed that this suffering that we show in these graphics is consistent and unfortunately growing in Boston. On this slide and with this graph, you see outcomes for the top areas of concern comparing city or state averages. The Roxbury community fares worse compared to Boston and the state, with the exception of congestive heart failure. According to the CDC, 7 of the top 10 causes of death in 2014 were chronic diseases. 86% of the nation's $2.7 trillion spent on our annual healthcare expenditures goes to people with chronic and mental health conditions. The next slide, we have topics and subtopics. If we want to think and talk about a focused conversation about the social determinants of health, data like the county rankings help us to localize these kinds of national topics. We'll take a closer look at some of the challenges that affect each of the key areas in Boston communities of South Dorchester, Mattapan, and Roxbury. Next slide. In looking at some of the determinants of health in the communities I mentioned, Mattapan, Roxbury, and South Dorchester, you can see that education rates are lower, crime rates are higher, poverty rates almost twice the state average. In these communities, greater numbers of people speak a language other than English in their home. So, many factors like rundown housing, exposure to environmental toxins, and poverty contribute to high rates of disease and death for the city's blacks. And the Globe article reiterates this information. The center event that we held in Roxbury, that event featured local and national experts addressing healthy aging in areas of, and this is an important list to listen to for maybe some ideas that you have for events yourself. The topics covered were nutrition, exercise, yoga, Tai Chi, mindfulness meditation, relationships, and they even covered conversations around technology. Attendance exceeded expectations. Participants were overwhelmingly positive and receptive to new conversations and possibilities. This event connected organizers with firsthand accounts of health concerns. It also stimulated thinking about developing a culture of healthy aging, and this aligns with Boston's work on enhancing its reputation as an age-friendly city. Next slide. There we go. Use the county health rankings to tell the social determinants of health story. In population demographics on the website, you'll find demographics around age and ethnicity and English proficiency. You'll find data to help you tell the story within the frames of things like level of education in a county, income inequality, unemployment, and violent crime rates. You'll also find information that will help you to analyze the implications of the built environment and what that means for members of the community when it comes to issues like air pollution and housing problems, or even commuting as a context for health. Bottom line, if we are to build awareness for the concept of a culture of health, we need to demonstrate to members of the community that we understand the point from which they want to tell their story. If we don't do that, we fail to establish our credibility as partners in the work that needs to be done. In the next slide, all of that brings us to this important framework for nursing and its role in improving the health of populations. We need to demonstrate our connection with communities in terms of building relationships with its members. We need to show we understand which issues are a priority according to the community members. And through all of this, we need to establish the reputation of nursing as a discipline capable of delivering expertise that does make a difference when we lead and when we're involved. And in this last slide, how do we change direction? This is the ultimate question for us as we seek to establish and define and communicate what it means to be engaged in a culture of health. And I'll now turn us over to Carmen.
Thank you so much, Dr. Washington. So overall, since the launch of the Campaign for Action, we have seen positive trends of increasing diversity among pre-licensure RNs and also among doctorally prepared nurses. And this should be encouragement to continue the work that we are doing and maybe also think about what we may need to do differently. Despite the positive trend, we still have some groups that are yet to have increasing representation of their race ethnicity group within the nursing profession. Also, even though we have seen progress in the diversity of our profession, it still does not represent that of the U.S. population. We know that diversifying our workforce is essential for achieving a culture of health. The innovation that we need for a culture of health and health equity will only come from spaces where there is diversity of thought and people. So on our next slide, hopefully some of what you have heard today will help inform your next steps in terms of developing new initiatives, goals, or fundraising plans. Both the data that is available from the campaign on diversity in the workforce by state and the data from the county health rankings can help highlight the workforce deficits, disparities within our communities and states, and help us think about not only increasing numbers for diversity, but also how to build and develop a diverse workforce to address community and public health needs. I think we can all agree that when it comes to caring for communities, a nurse's work goes way beyond the bedside. So next slide, the Culture of Health Framework. We can go to the next slide. Yeah, the Culture of Health Framework, more specifically the measures for each action area, can also be both a data point and a guide for how to connect a diverse workforce with community needs. So, for example, in spaces where chronic disease are the main causes of morbidity and mortality, are there opportunities to advocate for collaborating with local groups or nonprofits to increase access to healthy foods and enhance the environment for walkability or physical activity, for example? If voter participation is low, can nurses play a role in encouraging voter participation so that their healthcare needs and interests are considered in local policy. So now we would like to hear from you about how you feel about using some of the data sources that we have shared. And for those of you that are already familiar with these sources, how, if at all, are you using them? So perhaps we can have a reminder of how to submit responses.
If anyone would like to ask a question, they can press *1 on their telephone keypad, or they can use the chat function. And make sure when you're using the chat function up in the right-hand corner of your screen, make sure you send that to everyone. And Justin, operator?
Yes, ma'am.
Can you let us know when questions come in through the telephone?
There are no questions at the phone at the moment. Please continue.
Okay.
So this is Winifred, and I just wanted to offer to the Action Coalition folks. And Christine, can you give me a general idea of how many people were able to join?
It looks approximately 50.
Okay, great. These are two sets of data that can help action coalitions and their entities make important cases to potential funders in their states and or local communities about the value of how nurses, a diverse nursing workforce, can help to reduce the healthcare disparities or the health outcome disparities in your states. So I wonder if anybody on the line has already used either the dashboard indicators that we provide for that kind of an argument, or if they've used the county health rankings. Even if you've just used county health rankings, the dashboard measures, or another data source to raise funding, it would be nice to hear from you.
Excuse me, you have a question coming from the line of Mary Dico. Your line is open. Please ask your question.
Oh, thank you so much. I did just type in the chat box. Good morning or good afternoon, everyone, depending on where you are. We are using a lot of this data, and we've just wrapped up our 4th summit on diversity in nursing here in California. And, as much as we would like to do something statewide, we are so large that we're spreading this out, and we have 2 more coming this year, so that we've covered pretty much every area of the state, or, regional area of the state, that we can get large groups to come to these meetings. I just wanted to share something really interesting that came up in San Diego on Saturday at our summit. Students were in the room, and they mentioned that they don't necessarily identify. For example, there were 4 Hispanic nurses in the room who said they did not identify as Hispanic in any applications or anything they put in through nursing school. I found that really fascinating. They said they don't, as a generation, they don't see themselves in a box, so they don't check a box. Because we tried to drill down into it, like, why wouldn't you, so that we can collect that data? And then the other issue that the class talked about was the fact that so many of them are mixed race, and they don't even know what to check, so they just put other, and then I'm not sure how that gets captured in our data. Just thought I would share that. I found that fascinating.
Yeah, very much so. So Joanne mentioned one of the data points that has been building has been the more than one race category. So I think that satisfies the second. But I'm curious to hear from Deb and Carmen and maybe Adriana too about the thoughts about younger nurses of minority backgrounds not noting themselves on official documents as such.
Yeah, these were just new students, so I'm talking young, like Gen Z.
Right, like
yes.
17, 18 years old.
Yeah. Yes. This is Adriana. Thank you for bringing that up, Mary. Indeed, in talking to even some of my colleagues in the Native American community, Native American nursing community, we've shared that we do see generational differences in how new grads and students self-identify, especially within the Latino community, given the socio-political context and, younger nurses seeing themselves as American, more, first of all. And so in the Native American community, and I know Regina Eddy's on the call, one of our new diversity consultants, I know younger colleagues have shared that, that is one of their concerns, is that keeping the cultural practices of the Native American community, that, a concern is that younger generations, also there might be sort of this distancing from the cultural practices, not coming back to the tribal communities to practice. So these are issues that I've talked with colleagues about. Definitely, we notice it within the National Association of Hispanic Nurses. We definitely see differences in generations, and that's why I think our discussion and our definition of diversity is so broad to also look at how younger nurses entering the profession, what differences and what attributes do they bring, and what changes are we expecting to see in years to come as generations that are younger. Latinos tend to be younger in this country, so I expect that we will hear more of that.
I would agree. I would agree with that. That lack of wanting to be placed in a box is a sign of progress, thank goodness. And the whole diversity experience has always primarily been about the negatives of identity. And if the younger generation are having less of those experiences, then I'm going to applaud our progress.
Carlos Moran has raised his hand. So I don't know, Justin, could you open up a line for Carlos Moran?
There's no queue for Carlos Moran.
Okay.
There's a question coming from the line of Renee Mankins. Your line is open. Please ask your question.
Hello, this is Renee. I'm in Oregon, and we have coordinated care organizations, and I saw a comment that at least in Oregon we have community health assessments that are needed by both our public health agencies and our coordinated care organizations and the hospitals that are in those areas. And we've been doing some collaboration in certain areas to try and create a single community health assessment that meets the needs of the CCO, our hospitals, and our public health agencies. One of the issues that I think is a struggle for our Oregon Action Coalition is funding to move forward with initiatives. It's challenging to look at the whole state and volunteer efforts to try and bring things forward. We have this wonderful woman, Kelly Fox, who has been working with some of the CCOs in the metro area to support the showing of a movie called Resilience around adverse childhood experiences, with the hope that we can move that forward, at least in certain areas of the state, to look at what communities can do to improve or to change and move into more of a culture of health to support and reduce ACEs and adverse experiences in our kids. So I think what we're struggling with too is I saw also that There was a summit that's being done in California and how funding was put together around that. As we look more at holistic admissions in our nursing schools across the state, I think that we will start changing some of the dynamics of our diversity in students. But I also worry about how do we get students engaged in some of their community work to make changes broadly. And to me, the Oregon Action Coalition is one of the ways potentially to do that. But we're kind of stuck right now to move forward efficiently.
Mm-hmm. And this is Winifred. Your name is Kelly?
No, this is Renee Menken.
Renee. Hi, Renee. So I would be very happy to talk offline with you about all of this. So I'll offer that before others respond, because I am your liaison to the Campaign for Action. I mostly engage with Jana.
Oh, great.
So,
okay, that's cool.
Yeah, but if you could send me okay, so can you shoot me an email at wquinn@aarp.org so we could schedule a call?
Okay.
You have a question coming from the line of Victoria Vinton. Your line is open. Please ask your question.
Hello, everyone. I also agree about the wanting to identify. I don't think the millennial generation or the coming generation really, they see each other as a global community, so they don't feel the need. And like Dr. Washington said, that is progress. So I'm not sure how in the future we can to capture that information, but possibly explanations might help when considering to check a box to help people understand why you're wanting to know what race or ethnicity you are. My comment is on ways to reach out across your states. And in Nebraska, we kind of did a couple of mini summits in communities and used the county health rankings even early in our Action Coalition days. The county health rankings really is a great stimulus for conversation when you gather nurses, healthcare teams, community leaders, business. That is a great starting point for conversations, and using that in use with the community health assessments can really help them narrow in their view on what needs to be done on their community, because they've got the data looking at them, and it really engages participants to see that they don't want to be at the bottom of the list. They want to make sure they're improving their health in their communities. So we found using that data really helps engage communities.
Thank you for sharing that. That's very exciting to hear.
In the chat box, we have a question from Laura Smith about, Joanne, this is for you in terms of the, well, actually she's asking information at the local level. The state and county levels are good. However, agencies employing nurses compared to other agencies, are these data available?
Well, that's a great question. The data sources that are readily available at the national level and also often at the state level may or may not have a lot of detail locally. So the American Community Survey from the Census Bureau is an overall population survey. It's not intended to simply study nurses. It's everybody. And what that ends up meaning is that the numbers of people in the data set who are registered nurses for some of the smaller states in the U.S. are very small in that data set, which unfortunately means that even for states like Montana and New Mexico, we can't really say a whole lot about them with the American Community Survey. So for local organizations, your best bet is going to be to see what kinds of information organizations in your region have available. because it's going to vary a lot. Some will have a lot of information, some won't have very much at all, and there really won't likely be very many national sources of information for you, which is a shame, but it is what it is. It's what we can do. We do try to tabulate data at the state level to the extent possible to support AARP and the Campaign for Action. But, as I said, for some states, the data are just simply not that good. The IPEDS, the Integrated Post-Secondary Education Data System, though, might be worth taking a look at. I think that there's an archived webinar on how to access and use those data because that has school-by-school data that you can download. And so if you wanted, say, to look at all the nursing programs within a 100-mile radius of some hospital or community center or whatever it was, you should be able to get into the iPads and look at those schools and look at the diversity data of the graduates from those schools with the proviso that the bachelor's degree graduates are going to be mixed up, are going to have the post-licensure and the pre-licensure BSN grads mixed up. And then the AACN data, you may be able to get from them, also school-by-school data for your region. But for total population numbers, those would be harder to get for your overall nursing workforce within small communities or small geographies.
You have a follow-up question from the line of Mary Dico. Your line is open. Please ask your question. Miss Mary Dico, your line is open. Please ask your question.
Sorry, I had muted my line. I just feel like I want to share a couple other things because I can see some of the questions and listening to the conversation. I think a lot of our states are struggling with the exact same thing. One, I want to say that I am thrilled that our younger generation is seeing themselves as what we heard over and over on Saturday, as human beings, as Americans. And even those from born in other countries who presented, we had a rich panel of nurses new to America and what the challenges were, and it was fantastic. But even them, they just want to be Americans and one body, not looking at our differences anymore. So I do think, to Deb and Adriana, that is a step in the right direction. Also, with the funding issue, Renee, I think I am seeing more and more funding efforts popping up around minority, or mostly around health equity, which tends to impact our minority populations and our older populations. So I think we need to stay more connected when, as action coalitions, maybe just on the listserv or whatever, about things that we're seeing that one or more of us may not be eligible for, but someone else in our action coalitions could think about. And we're really trying now that we have a new diversity consultant here in California. We're working together closely. So I don't know who everyone's diversity consultant is, and maybe that's clear to all of you on the phone, but I think that's going to be a great relationship to try and spearhead potential funding. So it's just a suggestion.
And can I add something, Wynn and Carmen and Deb, to Mary's point? One of the experiences that I had in Arizona, this is Adriana, when I was president of the Phoenix chapter of the National Association of Hispanic Nurses, I met a lot of stakeholders in addition to healthcare systems, but businesses, education organizations, nonprofits that focused on the Latino community. And every time I shared these numbers of the workforce, there was a huge knowledge gap. They didn't know that Latinos were so underrepresented in nursing. And I had many conversations with funders about the care they had received, in whether they were in a hospital or their primary care, and they would say things like, now that I think of it, you're right, I did not see nurses that were bilingual or that, So know that while, we've heard this data and we know it, stakeholders that we are trying to engage, especially those that outside of healthcare, they don't always know this information. So I felt it was a very successful way to get their attention, and many supported our efforts to raise money for scholarships. And we, in 1 year, raised almost $100,000 in scholarships coming directly from non-traditional partners. And so this information is very helpful to those, especially outside of healthcare.
Thank you so much for that comment, because one of the critical things that we have to always remember is that as we celebrate our progress, because that's what this work is all about, moving us forward, it isn't the whole story. Mm-hmm. So as we continue to do the work and continue to celebrate our success, we can't let that dominate the additional work that needs to be done, because health disparities still exist, social determinants of health still exist, and we need to continue that work as well.
Yes.
So those are two perfect points on which I think we may need to close, unfortunately, our webinar, because we are at time. Based on everyone's comments, it does seem as though a number of you are using the county health rankings and community health assessments to generate discussion, bring awareness to issues in your communities. However, there are still challenges around revving up fundraising for larger initiatives, and that is what we are here for. And I think it's absolutely beautiful, as has been said already, that we have a growing generation that does see themselves as part of a larger community, and that is something to capitalize on, I think. The sky is the limit for a cadre of nurses who don't put themselves in boxes and see themselves as making a contribution to all communities, regardless of race, ethnicity, socioeconomic status. So I don't know if we have any other final comments from my co-chair or Dr. Quinn.
Deb?
I just am encouraged by the progress that we've been making, and I am definitely encouraged by the attendance on this call. And we still have work to do, and the data will help us to bring forward what that work is and how critically important it is. So tapping into our knowledge base and the data that will support that knowledge base is definitely the way to go.
Great. Thank you so much. And so this is Winifred Quinn again, and I want to thank our speakers and facilitators today, Doctors Joanne Spetz, Deborah Washington, Carmen Alvarez, and Adriana Perez. Thank you all very much. And really thank you to the conversationalists. I really enjoyed the dialogue toward the end. And a couple of things. 2 weeks ago, maybe it was even last week, we sent an email to the Listserv introducing action coalitions to their respective diversity consultants, because we have 2 new consultants, relatively speaking, and we also divided up some of the states who had previously worked with Adriana or Barbara Nichols. So if you could look for your email that had that information, and if you're not a co-lead and would like that information, ask your co-lead for that information, or you could shoot me an email, wquinn@aarp.org. The other thing Mary quickly tossed out was the idea, Mary Dickow tossed out the idea of using the Listserv to continue the conversation. Or any part of this conversation, I highly encourage you to do so. And our diversity consultants are also on that Listserv. And whether it's about fundraising, diversity, data, a combination of any or all of the above, it would be a really fun and important conversation to continue. So thank you all so very much once again. And again, this webinar will be available on our website next week, www.campaignforaction.org/webinars. And we have upcoming webinars in the future, and you could look for those on campaignforaction.org as well. And with that, I'm happy to end this discussion. Thank you all so very much once again.
This concludes today's conference call. Thank you for participating. You may now disconnect. Presenters, please stay on the line.